So I believe that there are some aspects that are completely unknown by patients. So that's something that must be discussed, which are essentially the sensitivity of the phallus. So most of the patients don't know the differences in between flaps in terms of sensation. So that's going back to the previous question. There's one motivation, at least one of the most important for what I prefer radial artery free flap reconstruction for total phallic reconstruction, is that the radial free flap is an innervated flap. You normally have between 2 and 3 cutaneous nerves that can be connected during surgery with both the nerve of the clitoris. We normally sacrifice one nerve and we connect it to the biggest nerve of the flap, normally the lateral aspect, which innervate all the skin of the phallus. And then we also do some anastomosis, microsurgical anastomosis from the ilioinguinal nerve and the other nerves of the flap. So that's something that really may lead to obtain an innervate phallus, okay? And that's something that must be said. It's not in 100% of cases, of course, but it's pretty high. Around between 75 and 80% of patients feel some sensation into the phallus and not into the clitoris. That's something absolutely absent, for example, in the pubic pedicle phalloplasty, which is a nice flap, very easy from the surgical point of view, with a low incidence of complication, but as just some cutaneous sensation that is normally limited to the first third of the phallus. So it means that from the medium and the distal part of the phallus are completely unsensitive. That's something that may afflict the quality of sexual intercourses, and there's also a role, as we said before, on the control of the pressure of the implant of the tip of the phallus. Because if you have an insensate phallus, it's difficult to regulate the pressure during sexual intercourses. So it may be a risk for distal extrusion. ALT phalloplasty normally has one nerve, so it provides some sensation. I personally think it's a flap that cannot be compared in terms of sensation with the radial free flap. And latissimus dorsi has a motor nerve, so it's essentially an insensate phallus at all. So this is something that is not well known by patients. So I believe that's something that must be highlighted because it's extremely important, because the sensitivity outcome, I believe, may strongly affect the overall outcome of the reconstruction. This is something that is not very known by the patients. Yeah, but that's something different because, of course, this kind of the transgender men undergoing a reconstruction will have two different sensations. They will have the erogenous sensation coming from the clitoris. I personally like to bury the clitoris if the patient allows to, because it gives a better cosmetical outcome of the scrotum, which is a male-like appearance. But the clitoris itself is buried at the base of the phallus, so can be easily stimulated through the skin, and it maintains this erogenous sensation. But here I'm talking about the sensation in the phallus, in the flap. That's something different. So it's something that has a detrimental importance in contributing in patient satisfaction during intercourses. Because if you have a complete insensate phallus, you may have difficulties to achieve an orgasm just counting on the sensation of the clitoris itself, because the clitoris is just at the level of the base. If you have the clitoris, which is stimulating during the sexual intercourses, and in addition you have the phallus itself, which gives pleasure, it may be much easier to achieve an orgasm, and it may be more satisfactory. But that's something that comes from my clinical practice. There's nothing scientifically explored or written on these aspects of the phalloplasty. It's something also difficult to assess, medically speaking, because we don't have a scale or questionnaires that can be administered to our patients.
I see.
But it's something that must be highlighted when choosing a phalloplasty.